Okay, for week 5, part 2, now we need to talk about the volumes and capacities of air that the lung can hold. These things are important when we talk about pulmonary function tests. So a lot of times in the hospital or in the doctor's office, they can run what are called pulmonary function tests or spirometry tests. And that just shows how much air your lungs are able to inhale, exhale, and hold. And then if that's normal or abnormal, and then they can see kind of what's going on. Remember that the lower the volume and capacity of air that your lungs can hold, the more indicative of a problem, right? And it is a problem because then you're not having that oxygen exchange and carbon dioxide exchange like you should, and then your tissues can be compromised in according with that. So we're going to start with the volumes first. So you're going to do a lab over this week called it's the spirometry lab, where you actually have a patient who's doing spirometry testing. But basically the first term I need you to know is something called tidal volume. Tidal volume is the amount of air that's entering and leaving the airways during your resting breathing. So as you're all just sitting here watching this lecture, you're doing passive breathing where you're not thinking about it. And that air that you're inhaling and exhaling just at rest is called the tidal volume. We measure volume in milliliters, and this is over time, but essentially I want you to focus on the y-axis. So here's your tidal volume right here. So you see this wave of an inhale, exhale, just passively. Notice how the wave's not very steep. This is just normal resting breathing. And so this space here between your end of your exhale and your inhale and then end of exhale, that space is called the tidal volume, and it can be measured, and normal is around 500 mils. All of these volumes are going to differ greatly per person, and we'll talk about what kinds of factors would take into account there, but that's tidal volume. Now, we know that we can always inhale more than we do passively, right? So you can always take a deeper breath in if you need to. So that's going to be the inspiratory reserve volume. So this is the volume of air that you can take in after your tidal volume. So as you're all just sitting here, just take a normal breath in, just passively, and then inhale beyond that. So we're going to take just a regular breath in, and then, right, and try to inflate your lungs as much as you possibly can. And that space beyond just your resting inhale is called your inspiratory reserve volume. So this is the amount of air that you could potentially take in if you needed to take a deeper breath than normal. Normal would be about 3,000 mils of air that you could take in. Your expiratory reserve volume is going to be very similar, except this is going to be how much you can exhale. So we also know that after you exhale, just passively sitting here, you could technically blow out more air if you contract a bunch of your abdominal muscles, right? So why don't you all try that here? So we're just going to breathe normal, and then, right? You can blow out as much air as possible. That's your expiratory reserve volume. So here's your tidal volume again, and here's the amount of air that you could exhale potentially. Beyond that, about 1,100 mils. Now, believe it or not, you can't ever exhale all of the air in your lungs. There's always going to be some left over that you just can't release. That's called the residual volume right here. Residual volume is important because we never want your lungs to collapse. They always need some amount of air in them at all times. So this is a special measurement. It cannot be measured by spirometry, but normal would be about 1,200 mils of air at any given time that you can never exhale. And that's going to be here below the expiratory reserve volume. So this is the residual volume here. Okay, so again, here's all your volumes. So you have your tidal volume, which is just your normal inhale, exhale at rest. You can always take a deeper breath in if you need to. That's going to be your inspiratory reserve volume, the amount that you could potentially take in. You can always exhale more than tidal, which will be your expiratory reserve volume. And then there's always that volume left in your lungs that never moves. Okay. So those are the volumes. Now we're going to talk about the capacities, which is basically about adding volumes together. So vital capacity, what is vital capacity? This is the maximum air you can exhale after taking the deepest breath possible. So if you're taking the deepest breath possible, think about what volumes we're going to take into account here. Obviously, we're taking into account tidal volume because that's just your normal breathing ability. If you're taking the deepest breath possible, you're taking into account your IRV. And then you're doing your maximum exhale as well, which is your ERV. So we're taking into account this, this, and this, okay? So here's your vital capacity. What we don't count with vital capacity is this residual volume because it's non-functional. We're only interested with vital capacity, it would be functional capacity here. So vital capacity is going to be your IRV plus your tidal volume plus your ERV. Okay, inspiratory capacity. This is going to be the maximum volume you can inhale following a passive exhale. So let's just say that you take just a normal breath out and then you just feel like you need to take a really deep breath in. Maybe you're going underwater or something like that. You're about to hold your breath. Okay, inspiratory capacity is going to be your tidal volume, which is how much air you would just breathe normal, plus this IRV. So that's going to be your inspiratory capacity. How much air can you breathe in total? Okay. Now, of course, they have to make it difficult here, and we don't call it expiratory capacity because that would be too easy, right? But we do call it functional residual capacity. So your functional residual capacity is your ERV plus your residual volume. So that's the volume of air that remains in your lungs after you breathe normally. Okay. So you just let out a passive exhale, and how much air is left in your lungs after that passive exhale. Okay, probably this 1100 plus this 1200. So vital capacity is very similar to total lung capacity. However, vital capacity did not take into account the residual volume. Total lung capacity does. So if we add up all 4 volumes, that is our total lung capacity. How much air can we potentially hold in our lungs at any given time if we wanted to, right? If you wanted to take the deepest breath possible and exhale as much as possible, plus that residual, what's left, how much air can our lungs actually take? And normal is about 5,000 mils. Okay, so you're going to do a lab with all of that with a patient, and you'll have to record all of those volumes and capacities. Here, you're going to see a chart just like this. I would actually just get your book out. This is from your book, and keep that really handy. So I said that this varies for everybody, right? The normals are going to vary. It depends if you're male or female. Obviously, males usually have a larger stature, and so their lungs are going to be a little bit bigger, able to hold more. Body size, right? People with a larger body size probably have a higher capacity. Age. People that are younger probably have more elastic lungs. But essentially, you can do pulmonary function tests to determine if there's a problem. A lot of times they'll test you for like COPD, maybe if you have really bad pneumonia, COVID, how well are your lungs functioning after those illnesses? And something else, I'm going to throw something else at you here, but some air that is going in actually never reaches the alveoli, which makes sense. Okay, so if we go back to a picture of the trachea with the bronchial tree and the lungs, all of those passageways have air in them. Okay, and only a certain volume of air can actually go into the alveoli of the lungs. Some air is going to still be hanging out in the bronchial tree, in the trachea, in your nasal passages. Some air is still there, right? That is what we call anatomic dead space. So basically the point of anatomic dead space is the idea that not every single molecule of air that you inhale is being used for gas exchange. Some of it's simply just sitting in the passageways. Okay. And so that would be everything that doesn't actually reach the air sacs. Now, some alveoli also might be non-functional. And so we call that alveolar dead space. Most healthy people don't have this problem, so this is negligible. But some alveoli may not be able to function and therefore not be able to hold air. So that's also just dead space. Or it can hold air, but it can't do gas exchange, right? So that's alveolar dead space. It's negligible because it's so small of a volume. So if we think about all of the air that's in our passageways, our trachea, our nasal passages, our bronchial tree, all of the air that's there that never reaches the alveoli, at least not in a normal respiratory cycle, right? That's our anatomic dead space. Then if we take into account any non-functioning alveoli, which is that really negligible volume, we call that physiological dead space. So physiological dead space is places that can hold air, but that air is not currently being used for gas exchange. Okay, the only air that's being used for gas exchange is what's in the functioning alveoli. It's about 150 mils in the average person. Okay, now this dead space, this air that's in this dead space, let's just say that you have air sitting in your trachea. In the next breath, that air that's in your trachea will be pushed down further and maybe make it to your alveoli on the second respiratory cycle. So that air is constantly being cycled through. Okay, so it'll reach the alveoli eventually, but not all of the air that you're breathing in each respiratory cycle is being 100% used for alveoli gas exchange each respiratory cycle. Okay, some of that is going to be in dead space. And so in that case, we need to know how well the alveoli are functioning and how much air they're actually seeing and working with, right? So minute ventilation is the volume of air moved into the passages each minute, total, right? So how much air are you breathing in? How much air are you breathing out? What you do to calculate that is your tidal volume, which is your passive volume of air that you can move, times your breathing rate, which is how many breaths you take per minute. So let's just say that somebody's tidal volume is that average 500 mils. Their respiratory rate, they take 12 breaths per minute. 500 times 12 is 6,000 mils per minute. So each minute, that person is passing 6,000 mils of air between inhalation and exhalation. Now, what this doesn't take into account is your dead space. And so this is just a volume of air that's moving, okay? But if we want to know how much volume of air the alveoli are actually working with and functioning with, that's a different calculation. That's called alveolar ventilation rate. What you have to do is subtract the dead space from your tidal volume. So yes, we're passing 500 mils of air with passive breathing, but again, some of that air is sitting in our trachea, our bronchial tree, our nasal passages, about the 150 mil. So really, we're taking in 500 mils of air each respiratory cycle, but we're only using 350 of it. And so if we take that 350 times 12, our alveoli are actually functionally using 4,200 mils of that 6,000 per minute. And this is the more important calculation because this affects the gas concentration. How much oxygen are we, is our body gaining, and how much carbon dioxide are we exhaling, and how much gas is available in our bloodstream at any given time. That's more importantly having to do with alveolar ventilation rate. So how can we increase our alveolar ventilation, right? So if our alveoli are not functioning really super well, then how can we increase that? Well, you can increase your respiratory rate. So the faster you breathe, the more air you're going to pass each minute. And so you can increase how much functional air is being used by the alveoli each minute. Remember that each cycle must fill the dead space before that new air reaches your alveoli. So you're going to have air sitting in the dead space. It will move down eventually to the alveoli and so on and so forth. So also the expiratory reserve and inspiratory reserve allow for your increase in tidal and alveolar ventilation. So essentially what this means is you can take a deeper breath in or a deeper breath exhale, regardless of your dead space, right? And you might need that during exertions. Like if you're exercising, you know that you can take deeper breaths in and out to inhale more oxygen and exhale more carbon dioxide according to your cellular requirements during that exercise. Okay. Kind of a short lecture here for this section, but in the next section, we're going to jump into the physiology now that you have this down. This lecture will really help you with your lab, however.